He directs addiction training programs for that university, chairs the American Board of Psychiatry and Neurology Addiction Psychiatry Examination Committee, and sits on the board of directors for the American Society of Addiction Medicine, ASAM, where he chairs the Publications Council, edits the ASAM Weekly, has been selected as ASAM's president-elect, and has just received an award from them. He is a retired Navy captain who served with the United States Marine Corps. Please help me welcome Dr. William He.
That, of course, runs us out of time, so I hope you enjoyed the presentation. I'll be interested to hear what comes out of this thing on top of my neck, even though the slides really are less there for you than to provide me with some backbone as I get through all of this. So humor me. The first slide, of course, I'm hoping that you will download the presentation when you get a chance. There are a great many pages in this that warrant revisiting, in large part to further acquaint yourselves with the properties of opioids, with the nature of opioid use disorder, what we used to just blandly call opioid addiction or opiate addiction. And then the ones like this that will tell medical students how it is they should select their career path. For those of you who are at a distance and listening in, we're just dealing with a momentary technical confrontation. The language keeps changing. I know at times it's hard to keep up with it for folks who are raised on the notion of drug abuse as opposed to drug dependence. The older style of describing a usage disorder as abuse or as dependence really reflected how many criteria you met in a panel of criteria. Substance abuse, of course, was seen as largely volitional usage that was leading to bad consequences, and dependence was seen as a version of misuse of drugs that, while leading to bad consequences, also could not be volitionally involved. Since the time of usage of those phrases, those diagnostic headings, we've come up with DSM-5, which supposedly is an improvement insofar as it describes usage disorder as a continuum, beginning with 2 or more of a series of 11 criteria. We're going to touch on those in a few moments so you can become fairly familiar with them again. One element of the whole maintenance of certification movement is that there's not too much I can say that will be useless, because it's going to be coming up for you over and over again on your CME and MOC requirement examinations. I say this from experience. In the past year, all 3 of my specialty boards came due at the same time, so I had necessarily to study for and write all 3 of them. I was 6'4" and 190 pounds. State that's total. In any case, one nice thing about the substance use disorders is that they don't actually change, but our perception of them may alter. Still sitting up. This was, of course, working flawlessly before you came in. You will believe me, but that's the risk. Okay. So I have no commercial contacts as I am muted, it says here. John, sit.
Oh, sorry.
I have no commercial contacts. I have no medical students or resident physicians who are harmed in the preparation of this talk. I have been known to prescribe medications on occasion and not taking any right now. I will warn you if I propose any off-label therapies. And just want to make sure that the folks who are at a distance can hear me. Great, thank you. So again, here are the objectives. They've been published. You'll get these when you download. These are the sort of things that you're expected to address whenever you're making a CE presentation. So if you get on the path to doing these things yourself, you'll get accustomed to this. At the end of this, you should get a working knowledge of the CDC guidelines, as well as the Department of Defense guidelines, which largely describe the prescriptive expectations of managing opioids with your patients. That is the therapeutic way of dealing with opioid use, not treatment of opioid use disorder. Recognize and provide initial management for those who have an opioid use disorder. Identify two major risk factors that are readily addressed in prevention of overdose deaths, and integrate their opioid prescribing practices with current understandings of opioid use disorder. By the end of this, which will be about 40 minutes or so, you're supposed to have an understanding of the whole world of opioid use, both therapy and dependence disorder. Now, what I'd really like you to be able to do is to have a conversation with somebody who has a substance use disorder that leads productively to an understanding mutually of what the problem is and how you're going to address it. And I'd like to think that we'll at least embark on that pathway before we're too far along. So let's begin by distinguishing between therapeutic effects of opioids, intoxication, repeated use of opioids, and substance use disorder, most of which will be substance use disorder for the remaining time we're together. The therapeutic effects you're familiar with, and probably even are familiar with the concept of the therapeutic index. That is the ratio between how much it is required to achieve an ideal therapeutic outcome and how much is required to kill the subject. Okay. That ratio, as it happens, you want to be as far away from being zero as possible. In fact, ideally, you should be using a medication that has no risk of killing the patient, but such substances don't really exist. Intriguingly, water, of course, has a therapeutic index. It is possible to intoxicate and kill with water, and then we get to the question of where the narrower therapeutic indices are, and they do tend to operate most cogently in the area of sedative hypnotics such as barbiturates and with the opioids. Now there are some opioids that are safer than others, and we'll touch on that as we go a little further along. But nothing is completely harmless. At the same time as some of them get a bad rep. I ask that when you consider dramatic statements made by patients such as, my OxyContin addiction began with a visit to the dentist, or when you read this in newspapers or hear it on television, it is actually an effort, and not one that should be criticized on the part of the patient, to assign a rational construct to their usage. And so what they're doing is saying, well, this is what makes sense to me. It started for me when I first used this. Addiction is a much more complex disorder than simply an initiating event leading helter-skelter to the development of a dependence. I've got a little bit flippant here in suggesting that an analogy for this would be I drowned. And so my initial exposure to water was when I was bathed as a baby. Okay? But that has some analogic value when looking at the idea that, well, the first time I had OxyContin, I saw God, and from that point on, I decided I would be an addict. This is not the intention of people who take opioids and then find themselves somewhere down the path, unable to stop taking them, or organizing themselves around taking them. So if there are important takeaways, it's this. While management of the withdrawal is important, it's actually necessary, it's not a sufficient component of treatment for opioid use disorders. We get all balled up at times in terms of what the appropriate management strategy is for opioid withdrawal, when in fact it's the longer term and actually more difficult challenge of keeping people re-engaged in their original ambitions becoming adults than the business of getting them to just to be comfortable during withdrawal. Saying that somewhat clumsily, but the fact is the medications used for treatment or withdrawal are many, but not necessarily requisite. If I were to withdraw from alcohol or from barbiturates, I might suffer a significant risk of mortality. If I withdraw from opioids, the only real risk of my withdrawal state is that in the course of the withdrawal, I become motivated to go do something really stupid, okay? Like rob a convenience store or do something like tick off my dealer. Those things will get me killed, okay? But by and large, withdrawing from opioids, except for the misery that it engenders, is not a particularly lethal event. So that said, the treatment is effective, the treatment capacity is alarmingly limited and underdeveloped, and generally misidentified. We tend to focus an awful lot on suppressing the symptoms of withdrawal, when in fact the actual treatment challenge exists in the reconstruction of somebody's life as it would have been before they started using the opioids. So when we initiate this, and we proceed from several different origins, ranging from curiosity to some sort of analgesic or pain management, the idea is to try and preserve your opioid prescribing capability, but how do you do this safely? And the answer will involve some necessary tension between your essential humanistic and nurturing care at the core of medical practice and the obligation to do no harm. Because you certainly didn't get into this business expecting to be a policeman. It requires a certain measure of perspective. I put this slide up in large part to remind myself of the daily confrontation I have with perspective when I'm dealing with my 11-year-old nephew. Okay? So I'm standing with him at, anybody recognize the site? It's the Golden Gate Bridge. It's one of the pylons for that. And there's this massive big bronze plaque that contains the name of every really important person involved in the building of the bridge. So these are engineers, these are financiers, bankers, they are all the people with large bellies and larger egos, and the usual stereotypes of folks who are important, okay? There they are in bronze. At this moment, Nalu turns to me and asks a question which, for some reason, my wife catches on the camera, and the question is this: Uncle Bill, didn't you tell me that there were some people killed in the making of this bridge? And I go, yeah, I think so. About a dozen or so died. The actual number is 13, by the way. At this point, Nalu says, okay, so where's their plaque? A concept that had not occurred to me during the 70 years I've been on the planet was, where is the plaque for the people who built the bridge? So in looking at addiction, I asked that as we run along, try and realize that the people who start using opioids and become ultimately, and I will keep using the word addicted because it has actual salience in this matter, who become addicted did not start out with that image of themselves in mind. And a certain amount of perspective is required to regain a rational approach to the management of their pain and also to see how to guide them out of what they've gotten themselves into. Two different images of Morphea, Morpheus as a somewhat heavenly figure, and Morpheus injecting herself, or Morphea injecting herself with heroin. Of course, we've had this around. Everybody's seen this slide repeated times. But what I find particularly useful about this heroin being marketed by the Bayer Company as a therapeutic agent back in the early 1900s is that in the same advertisement you see a variety of agents who have just come out. Were all miracle drugs, aspirin, phenacetin, agents that are, of course, not opioids, but intriguingly probably have caused at least as much lethality. He is here to remind me that when the time comes for me to have my myocardial infarction or whatever it is that causes me grave pain, I'm hoping there will still be morphine around, and that a large part of the approach to opioid management consists of how you view it. This is Nalu's older brother passed out. Arguably, he has subjected himself to intoxication. Between the cookies that you can't see and the tryptophan, he's managed to get a serotonin blast that has laid him flat on his back. Okay? If I were to suggest to Kai that he in fact was a drug user, he of course would be very puzzled by that. But he certainly he certainly meets the criteria for intoxication. Let's distinguish it from substance use disorders then, as I promised. The substance use disorders in DSM-5, I'm going to start speaking fast so I can catch up to the time I lost here. Problematic pattern of substance use leading to clinically significant impairment or distress. You've got to have at least two of the following. In the old DSM-4, you have this complicated array of substance abuse and substance dependence. Now, it's everything that leads to misuse of substances in a somewhat foolish fashion that doesn't support your survival. There will be 11 of these criteria. You only need 2 to describe a substance use disorder. And then the next step in this is determining how severe, or what the duration criteria is. So, taken in larger amounts or over a longer period than was intended. People do not customarily eat broccoli in larger amounts or for longer periods than intended. So this is unique to the substances of addiction. There's a persistent desire or unsuccessful efforts to cut down or control substance use. Again, using broccoli as an example, folks will recall that the elder George Bush banished broccoli from the White House kitchen at one point along the line, saying he couldn't stand the stuff and he never wanted it served again. Very few people complained, and by the same token, there was not an irrational relationship between George Bush and broccoli. And yet, folks don't generally have any difficulty stopping that in the same way that they have of stopping opioids. A great deal of time spent in activities necessary to obtain the substance, use the substance, and recover from its effects. If there is one mantra I would like you to have in mind when you are addressing the question of is there a substance use disorder, this is the single criterion out of all of the 11 criteria that probably has the greatest salience. So if you can recall that too much time being spent getting it, using it, and recovering from it, then you're pretty well on your way to making the diagnosis. Craving or a strong desire to use the substance sounds useful, but it's always difficult to measure craving. So it's probably, actually, from my standpoint, the least useful of the 11 criteria. Recurrent substance use resulting in a failure to fulfill major role obligations at work, school, or home. This is a tricky criterion, particularly when we're talking about doctors who use substances. The room is filled with doctors right now, so let's talk about your susceptibility to this. If in fact I were to inventory the performance of the doctors whom I see who have substance use disorders, I would find, as I always have found, very few of them are failing to perform well. This is the least sensitive criterion of all of the criteria, is whether or not somebody's substance use is impairing their work. Do not wait for this to come along, okay? Because the last thing that goes out of the addict's life is going to be the work effort. It's very specific as a criteria. It's not very sensitive. And in large part because if you allow it to interfere with your work, you don't get paid, and pretty soon you're not able to pay your dealer. It's kind of a crude way of describing it, but there's no alcohol food bank or no substance use food bank. Continued substance use despite having persistent or recurrent social or interpersonal problems caused by or exacerbated by the effect of the substance. We'd all expect that to be a classical criterion. Important social, occupational, and recreational activities are given up or reduced because of substance use. Recurrent substance use in situations in which it's physically hazardous. Substance use continued despite having knowledge of having a persistent physical or psychological problem that's likely to have been caused by or exacerbated by the substance. Now, this is one where the medical students are really encouraged, and the residents, to remember the patient doesn't necessarily know what you know he has or she has. So when we're talking to people about how could you let yourself get so sick, how could you let your cirrhosis develop or keep drinking like that, it's not necessarily uncommon to have them say, well, wait a minute, you mean alcohol caused this? The criterion is not met unless you actually provide them with the information first. So if somebody comes in with cirrhosis from alcohol consumption, that's not a criterion, interestingly enough, for substance use disorder. If they come in and they've been continuing to use the alcohol in spite of you're having the presence of mind to tell them that it's bad for them, then that meets the criterion. So you have an essential function here in confrontation. tolerance, meaning you're using more in order to get the same effect, or you're getting less of an effect as you use the same amount that you've been using. And withdrawal, of course, being whatever the withdrawal syndrome is, or you're taking something else to mask the symptoms of the withdrawal. Either of those is a criterion. And we'll talk about what the actual withdrawal symptoms are in a few moments, because the charge that was given to me is talking about recognition of this as well as referral to treatment. But just by way of reference in terms of the duration, early remission is considered greater than 3 months, but less than 12, and anything over 12 months is considered permanent, or prolonged or full remission, sustained remission. It's mild if it's 2 to 3 symptoms, it's moderate if it's 4 to 5 symptoms, and it's severe if it's 6 or more symptoms. This would be impossible to remember for the boards if you can just recall that half or approximately half of those criteria or more constitutes severe, and anything less than that is mild to moderate. I doubt seriously that you'll encounter questions that would be more specific. And I'm speaking of the American Society of the Addiction Medicine Boards, which, by the way, you're all eligible to take at this stage in its development. Organization around acquisition, use, and recovery from effects of the drug I mentioned, dosage and frequency are not the issue. In none of the criteria is mentioned what the volume of substance is that's required to achieve a substance use disorder, or how often you have to use. It's actually not about how many times during the week you get drunk. In fact, it's not even about whether you drank enough to get drunk. It's what the consequences are of that. Adaptation and deterioration are the hallmarks of any substance use disorder. It just went out, John? Good. All right, it's got a mind of its own. I see. Ambivalence is the dominant psychodynamic. Now, once upon a time, I was a perfectly rational emergency medicine physician, and then I went on to become a psychiatrist, which at that time in my life, I thought was an idiocy without parallel, but it did allow me to start using such pompous phrases as ambivalence is the psychodynamic. When actually what I was trying to say, but couldn't in polite company say, was that in every addict's head, I'll explain this in a moment. In every addict's head, there are 2 voices. One of them is saying, wow, this stuff is great. This is the whole reason for living, is getting high on this stuff. And then there's another little competing voice, which may be listened to with varying intensity, that says, this shit is killing me, okay? And it's those 2 voices, that's the vulgarity, sorry, it's done. Those 2 voices that constitute the faces of Janus. This, by the way, is the summed up Janus, which is a car that, in fact, you can sit in on either end and drive from either end. It achieved limited popularity in Czechoslovakia when it was first constructed. It was disconcerting to the passengers because they weren't really certain which way they were supposed to be facing, and it had a 15 horsepower engine, so that was its final death knell. Okay. Now, for those, this is largely a geriatric fellow population here as well, so I want to reemphasize this is very much within your kuleana, this business of drug dependence or alcoholism, because we're talking about chronic illnesses, and you guys are the experts in chronic illnesses, if there ever was any category of profession, it is yours. And the characteristics of chronic illness are these: late onset of clinical symptoms, an unpredictable course, and a complex etiology, and it's progressive. Chronic illnesses are generally thought of as being progressive without cures. Remissions, maybe, but that's the therapeutic benchmark. You don't really expect to get a cure in chronic disorder. And the treatment is interestingly behavioral. What do you mean it's behavioral? What about diabetes? The treatment of diabetes is largely behavioral. It is the obtaining of compliance or adherence from your patients in the administration or self-administration of the medication, in the maintenance of the health that's required in order to get through that disease happily and with a long life. Yeah? I mean, the medications have been largely the same with some variations since Banting and Best in the mid-1920s. It's been largely a question of whether you could get people to use them properly or to take care of themselves. That's why I have the arrogance to say that it's a behavioral disorder. Now, this is to remind you, again, for those maintenance of certification certificates, what the withdrawal symptoms are like. If in fact you can simply in your mind's eye picture what it's like to get somebody inebriated or intoxicated with opioids, then it's real easy to figure out what the withdrawal symptoms are. Because, as we review in our mind's eye, what the effects of opioids are, they are, of course, analgesia. They involve meiosis, pinpoint pupils, some narrowing of the pupils. They suppress peristalsis, so that in fact if you have diarrhea, opioids are a good choice for jamming things up, for at least diminishing diarrhea. And among other things, in addition to relieving pain and serving as an analgesic, it will suppress cough and indeed suppress respiration in general. The reverse of all of those is what the withdrawal syndrome is. And that's a good rule for any drug of intoxication, is look what the intoxication pattern is, and then try and reverse that. Well, nobody knows what carpet paper is anymore, but anyway, try and imagine a negative of that image. And you've got it, which is that people become hypertensive, they become, they will be tachypneic, they have bone pain, a very strange syndrome, which essentially means feeling like the bones are blasting open or breaking open. There's no accompanying pathology, visible pathology that can be seen with this, but the experience, trust me, is profound for those who have it. And of course, they're itchy, they are dysphoric, they cannot sleep, they have all of the reverse of the symptoms of intoxication. This is probably not worth memorizing, but is worth mentioning as, again, something for the boards. If you see a Greek letter describing a receptor site, then it relates to opioids. That's the summary statement for this. So mu receptor sites, kappa and sigma receptor sites all have to do with various types of opioids or with opioid ligands. In the case of the two mu receptor sites you see here, they're responsible for probably 80 to 90% of the symptoms and of the therapeutic effects that we want to achieve with opioids. Kappa and sigma receptor site activity can produce what you see on that side of the slide, spinal analgesia and dysphoria. In the case of sigma receptor sites, hallucinations and convulsions if they are overstimulated. No matter. If somebody ends up saying, is this associated with opioids, GABA receptor sites, NMDA receptor sites, mu receptor sites, or sigma, or whatever, pick whatever there is that has a Greek letter. Well, why is that important? Because it emphasizes the fact that there is no one opioid drug. There are multiple manifestations of opioid effect that are largely related to which ligand. Sorry, when I pause like that, it means that the screen is doing something wrong. So in this case, we've got ligands that have agonist, partial agonist, and antagonist effects. And those examples of that for agonist effects are a morphine-like effect, such as with heroin, and that would be principally mu1 receptor sites. Partial agonists are weak morphine-like effects with a really strong receptor affinity, such as buprenorphine, or to some extent methadone, which we'll talk about in a moment. And antagonists have no effect in the absence of the opioid or in the absence of opiate dependence. And a good example of that is naltrexone, which we will use for management both of opioid use disorders and, interestingly, alcohol use disorders. Okay? Now, what I've included in when you download this or when you get the electronic version of this is an instrument for doing a quick survey. It's one thing to stand at the bedside or at opposite the desk from someone whom you believe may have difficulty with an opioid use disorder and come up with your own questions. It's sometimes much easier just to have a cheat sheet and then allow that to lead into an open conversation. Whereas in psychiatry, we always encourage the practitioner or the resident or the student to begin with open questions. This sometimes makes it a more convenient conversation that will then expand. So I just propose that you might want to use the DAST as an introductory way of getting people to talk about what their usage pattern is. Again, remember, the volume and the frequency are not the issue. The consequences are the issue. And so once you were to get these questions answered, and there is a scoring system here where really just about anything on up to 2 positives is an acceptable variant of normal, but anything more than that on up to 8 should suggest the need for further drill down and further, more intensive inquiry or interview. Let's talk a moment about methadone. Keep track of the time here. This is actually the single most, for all of the bad press, successful treatment modalities in this or the last century for opioid use disorders. The story behind this, and I apologize to people who heard me tell this before, but I actually got to meet Vincent Dole on a couple of occasions while he was alive. And he was a wonderful, soft-spoken, very sweet man, about 6'4", 6'5" high. And Marie Neiswander, who was his partner in this endeavor, was a tiny Jewish psychoanalyst, probably about 4'10". That's why she's sitting on a stool in this photograph and why he's sort of hunched over, so that it doesn't turn into a fucking jetpack. But they met each other at a party. Vincent Dole was an investigator at the Rockefeller Institute back in the early 60s, and his principal area of interest was opioids, or at least opioid receptor sites. He would get off the subway each morning and bum hop over all of the stretched out forms of heroin users in Morningside Heights, all along the sidewalk. And he would get to his office just distressed for a bit at the terrible things people were doing to themselves, but felt powerless to do much more than to try not to tread on them as he was making his way to the office. Marie Neiswander had a nice practice going on over in the island, and she would go up 2 or 3 times each week into Harlem, and she would try to do psychotherapy with heroin addicts. Kind of a novel idea. And she wasn't always very successful at it because that's not the desired initial approach, at least, to opioid dependence, and certainly not to heroin dependence. But she did create loyalty among her patients. And they loved the fact that she loved that. So she was accepted in a way that a lot of other doctors would not have been, even though she didn't have all that much that was practical to offer. So they used to get together at a party, compare notes, and Vincent says, you know, I've been working on this stuff that has a really, really long half-life because it's so tissue-bound that at any given time only 2% of it is in the blood at any moment. And it blocks every other opioid you could possibly want to give to somebody. I'm willing to bet that that might suppress the symptomatology. Marie's contribution to this was to say, if I could get their attention for a while, if they weren't always either tweaking or nodding, then maybe the psychotherapy would have some benefit for them, which proved to be correct. And so the combination of a cognitive behavioral approach with some element of psychotherapy and a medical management approach in the same patient proved to be, as I say, the most successful opioid management program yet in this country. Vincent's words about this was, it was important to get the patient out of the street long enough to get the street out of the patient, okay? And to this day, folks are still alive and breathing and doing well who were introduced to methadone in the mid-1960s in New York, which is an indication of how safe the medication itself is when it's properly prescribed. Now, by contrast, methadone is a full agonist, a full mu opioid agonist, which means when it pushes that button, it pushes it forcefully and firmly and without any equivocation. Buprenorphine is a partial agonist. Okay, and there's no good elevator button pushing analogy for that other than to say that it's a little more tentative, and when it pushes the button, it makes its way up to a certain level and won't let you get above the 3rd floor in the elevator. With buprenorphine, there is a good blocking effect to other opioids, but once you hit a certain threshold, once you hit this point in terms of the dosage, the opiate effect, then you can keep giving it and giving it and giving it, and there will be no further objective or subjective effect for it. It's effectively blocking itself. So it makes it a very safe drug if it's not mixed with something else like benzodiazepine barbiturates or other types of opioids. Now, the effect of this is that the person who is taking buprenorphine in order to block the effect of the cravings for other opioids may decide to get experimental and try taking more than he or she was actually prescribed. They can do that, but all that will happen is they'll run out of a prescription that much faster. There's no real lethality associated with it. Probably people will get tired of this, but chief lethality at risk in buprenorphine alone is that you might aspirate the bottle cap, okay? Whereas with methadone, the further you go up, there is almost not a geometric, but a fairly linear association between dosage and risk for mortality. So the therapeutic index is actually very tight. It's very narrow with methadone. And you must be careful because methadone carries within it an improvised explosive device in the form of that tissue binding I mentioned, such that when you are initially giving methadone, if what you assume is, oh, okay, I'll give this 3 times a day, and they look fine at the end of the day, and you keep giving it 3 times a day, if you're not careful, they will in fact reach saturation point in terms of protein binding, and they will begin to push up the blood levels of methadone to an insupportable point where in fact it suppresses respiration. Said a little more simply, you can kill somebody by giving them too much methadone and not paying attention and seeing them. The chief rule in giving methadone is to make sure you're monitoring the effects day by day during the first few weeks. And then it becomes actually quite safe. So buprenorphine's advantages, not encumbered by regulatory structure of methadone dispensing. Methadone can only really be dispensed through a methadone maintenance treatment facility. Buprenorphine can be prescribed through physicians' offices. Any of you can get a buprenorphine waiver by taking a fairly simple training. It has a better safety profile in overdose, as I've mentioned. Minimal subjective effects, such as sedation. There's a lower level of physical dependence, and it's not methadone, which just means that methadone has bad press. So it'll be easier to get people to take this initially because everybody is convinced that methadone is just giving an opioid to replace other opioids. Buprenorphine's disadvantages, it won't necessarily meet the needs of patients who've been on high dose of methadone before or who had very high heroin requirements. For whatever reason, it's not a one-size-fits-all medication. So you will find yourself as you get up into the higher reaches of buprenorphine, some patients who will say, it's not working, doc. And those are the patients who need to go back on methadone and be allowed to reach their own level on that. That will probably account for somewhere between 10 and 15% of the general population of opioid use disorder patients. So most people will do well on buprenorphine. There's a greater medication cost, not an insignificant point. It is administered either as a film underneath the lipids, essentially, so it's buccal medication. It's not actually absorbed well by stomach. Minimum subjective effects also. Lower level of physical dependence. The patients can stop it, and there will be no severe withdrawal symptoms associated with it. They'll be able to get by even if they're uncomfortable. And it's not detectable in routine urine toxicology screening. That's another disadvantage, although the toxicology screenings are being upgraded. So as long as we're talking about opioid blockers, and because everybody's been hearing all the press on this next subject, I'm going to deviate for a moment. This is a digression. It's on to naloxone. Everybody's heard about giving everybody walking the street a syringe full of naloxone so that you can take care of the poor passed out opioid addict, right? I would submit to you that that's not such a great idea. And it tends to subvert the appropriate response for managing the unconscious or unresponsive patient. I gave you a reference here, which is an active link if you download it to the New York State Working Group on this. But American Heart Association guidelines and those that are recommended by our own emergency experts here. Why is this? When you encounter a down patient, it doesn't matter whether you know from the track marks or from the testimonial of their significant other that they are in fact a heroin addict or an OxyContin addict. It doesn't matter. The appropriate approach is high efficiency chest compressions, CPR. Not even respiratory support. You don't do respiratory support for cardiac arrest routinely now anyway. That's actually just not necessary. Chest compressions, if they're vigorously applied and applied at the right rate, are sufficient and actually better than the old style of alternating respiration and chest compressions. Anyway, it's not important because in this sense, if you were to give the naloxone and then wait for an effect, if nothing is circulating the naloxone, it won't have an effect. So you must do the chest compression regardless of whether you're administering naloxone. Anyway, enough for the digression. Note too, by the way, that all the first responder units in this state carry naloxone already. There isn't any particular reason for every policeman or for every even doctor to be walking around with a naloxone injectable. So, okay. Now on to an important sideline. There is an attempt right now in multiple legislators, including our own, 16 on the mainland last count, and here, to authorize the use of cannabis in the management of opioid use disorders. That is to prescribe it, as it is prescribable here, in order to treat both the withdrawal symptoms and the substance use disorder. I won't recite all of this to you other than to say I've been through the literature. You're going to have to trust that the 16 citations that are used to support usage of cannabis for opioid use disorders have nothing to do with opioid use disorders. They actually all support the notion to some limited degree that cannabis may be useful in the management of pain. That's not the same as saying as management of opioid use disorders. And in fact, out of the approximately 150 other citations I reviewed, there was evidence to suggest that it makes opioid use disorders worse. So what I'm a little frightened of right now is the legislature in its good-hearted intention to take care of people with opioid use disorders is going to authorize a methodology that in fact makes people worse. I would submit to you that before you start getting seduced into that mindset, which is one of comfort, and which is secondary to our natures as clinicians, to first look at what the actual evidence basis is for giving cannabis in that regard. And it's not very good. Probably because cannabis is not a medication per se, any more than cinchona is the same as quinine. Okay? Cannabis is about 100 different cannabinoids, some of which may actually have some utility, but is inadequately studied. Just emphasizing the fact that there is more to injury, more to substance use disorders in terms of injury than simply the intoxication or overdose. There are social, financial consequences, biologic consequences, psychiatric consequences, aggravation, both in intoxication and withdrawal of other psychiatric syndromes. I'm going to pass over this for a moment because I wanted to mention once again that there are non-pharmacologic approaches to substance use disorders and to opioid use disorders in particular. The therapies range from group, milieu, and individual therapies with names like cognitive behavioral therapy, motivational enhancement and motivational interviewing, and 12-step facilitation. These are all interpersonal therapies, and they are ultimately the mainstay of the real purpose of rehabilitation, which is to get somebody back to that point in their lives that they had abandoned when they first started using drugs, and on the road to maturation and adulthood. Mutual assistance, you're familiar with in terms of AA, Alcoholics Anonymous, or Narcotics Anonymous. There are other groups out there, and loyal as I am to 12-step groups and their utility, it would be unwise to dismiss the other groups. Not in the words of a song that is more my generation than yours, if you can't be with the one you want, not the one you're with. Smart recovery, moderation management, SOS, have variable outcomes, but they are conclaves of people who are like-minded and will support each other in terms of staying recovered. If the primary purpose of recovery is in fact to achieve independence and maturity, then there are many roads to that conclusion. Settings for treatment: hospital, residential, intensive outpatient, all of these can be ascertained by using what are called the ASAM criteria. ASAM criteria are really just an algorithm that describes what level of treatment is appropriate to somebody's particular complex of addiction. Withdrawal risk, flight risk, cognitive function, and the rest. Examples of previous efforts, just to remind us that we've had this with us for centuries now. This was probably the largest single hospital in the country in 1930, was the Lexington Federal Hospital. Variously characterized as a prison or as a hospital, it was the one humane site you could go to on the eastern seaboard for treatment of opioid dependence. There were similar hospitals that have long ago closed up shop. their whole modality for treatment consisted of isolating people from the opioids and then treating them humanely, feeding them, exercising them, but without much more than that to offer, and of course commonly resulting on discharge and relapse. How to safely prescribe opioids? These are slides I will not go through in depth, other than to tell you that since 2016, we have had at least 2 sets of management guidelines produced in this country, one by the Department of Defense and the VA, another by the CDC, and they are excellent guidelines. They will tell you how best to manage the long-term and short-term needs of people who have pain, should be, and the management of the particular agents. Speaking haltingly because I know I'm having to speak fast here. Countries had opioid use disorder in its history since well before the Civil War and consistently since the Civil War. And we've not shown very much consistency in how we treat this. Doctors have to be a little bit cautious. My only real reason for putting up this slide is as a mnemonic to me. Up until 1914, doctors were permitted to prescribe opioids with wild abandon to people who had pain. And in fact, it was considered appropriate to manage with paregoric anybody who wanted to come off morphine or other similar opioids. In 1914 came the Harrison Act, and the Harrison Act, while not specifically targeting physicians, principally impacted them, and in essence said you may not give opioids for management of opioid use disorder or opioid addiction. An awful lot of doctors went to jail and stayed in jail from 1914 to the mid-1920s. It was a horrendous outcome. Interestingly, that is immortalized in the buprenorphine waiver, which you will have to sit for if in fact you want to prescribe buprenorphine. The name itself, buprenorphine waiver, the full name is buprenorphine waiver for the Harrison Act of 1914. And it is that you are permitted now by a special concession from the federal government to prescribe a medication out of your own office that effectively takes the place of opioids. I'm going to go pass over the comment. I wish we'd had more time for me to talk about John Strasser and his very good work in this subject. But what I wanted to do was identify in the subsequent slides that you may want to look at both the DoD-VA criteria and the CDC criteria, which I have put down here in the resources component. The guidelines actually are fairly brief. They will give you good instruction as to what a safe dosage would be and how to manage both initiation and withdrawal of opioids and what not to do. If I was to summarize it in one sentence, it is to titrate the medication to the patient's observable needs, and to not mix the medication with sedative hypnotics. That's too short of sound bites, but that's what it comes down to for the moment. So as you look through the handout, you will find that there are 16 suggested guidelines that give pretty good common sense advice about how to manage this. I'm a little worried that we're coming up on the end of the hour, Kamal, so let me get down to some of the final conclusions. Okay, part of both sets of guidelines is an encouragement to convert the medication that you're providing somebody to milligram morphine equivalent, MME dosages, to try and rationalize your understanding of what the particular dosage should be. So while you can't make that out from where you're sitting, you can certainly make it out on the screen a little bit better. There's actually a table for conversion that goes according to which opioid you would be using. Codeine, fentanyl, hydrocodone, and so forth on down to methadone, morphine, oxycodone, and oxymorphine. And the equivalents to morphine are listed in the right-hand column. Notice that with methadone, it varies according to what the total dosage of methadone per day is And what that reflects is what I was talking about earlier in terms of the trickiness of dosing with methadone for pain. That is, that as you get higher and higher full daytime doses, it gets riskier and riskier. The actual morphine milligram equivalents go up with that. I included a number of resources in the same handout. There are websites, there are full free texts on this, and I apologize for the somewhat amateurish business of running out of time at this point, but I'll be happy to hang around afterwards and answer any questions. I'm sorry, but that's it. We're done. Open for questions? Got a couple minutes. Sir.
I work for a hospice agency,
Mm-hmm.
and then some people takes methadone to hospice. And my understanding, so in order to get the methadone from the clinic, they need to go there, day or a week. But in hospice, I have my understanding, because if they high pain, we can divide the dose into feet, and then if you did that, maybe you can prescribe it.
So the question has to do with appropriate methodology for prescribing methadone. And if you know that you're giving it explicitly for management of a substance use disorder, then it truly does have to come through an MMTP, through a methadone maintenance treatment program. But they can provide take-homes, which actually allow for up to a week at a time of methadone doses being administered or being given to the patient to keep in the lockbox. Now, when you're managing pain, it's a different matter. You are fully authorized to prescribe methadone for the management of pain, but you want to make sure that your documentation shows that that's what it was for. And not just the patient goes, oh, I have to have pain? Oh, yeah, I've got pain. Okay, this is more a question of fidelity in terms of meeting what the patient's requirements are. There has been a lot of discussion over the years in terms of how to manage the particular issue that the questioner brought, but you may not have been able to hear, which has to do with the care homes, either the SNFs or with the intermediate care facilities. As it stands right now, so the Narcotics Enforcement Division of the state of Hawaii understands that, and so far we have been reassured by the executive of the Narcotics Enforcement Division that there will not be an expectation, an unrealistic expectation of conformity with the law when it comes to management of pain with those patients. And as I understand the Narcotics Enforcement Division's concerns to be, they're not really looking for the isolated practitioner who is giving somebody methadone for management of pain. They're looking for the folks who are really maintaining a private pharmaceutical dispensing agency. Probably not a completely satisfactory answer, but you can prescribe, and in fact, if they have a substance use disorder, you can make arrangements for that to be either delivered or picked up once a week. Sir? When do I give tramadol? Every few years, the question is what I think of tramadol. Every few years, a new synthetic opioid comes out with varying degrees of mu receptor activity. And every few years, when it first starts out, it ends up being unscheduled because, of course, its potential for causing dependence has yet to be determined. And after a few years go by and a bunch of people start getting strung out on it, then the FDA comes back and reschedules it. This has been the case now with a whole host of these medications like Stadol and Talwin and the like. And of course, now we find that tramadol is scheduled as well. It's a useful opioid. There's no bad drug. It's just largely a question of how this is employed. As I say, I want morphine to be available when I have my heart attack. And tramadol has actually got a good therapeutic index. In many respects, it's as safe an opioid as any opioid can be. Some of the folks who have attempted to use this for chronic pain management, however, have found themselves getting seduced into the belief that because it has a relatively lower potency than oxycodone, that in fact it can be given for longer periods of time. And I don't know that that's actually true. I think it's probably got just as much capability of inducing a substance use disorder as any of the others. The real risk used to be for doctors and nurses, because it not being scheduled or controlled meant that it could just be written for on a plain prescription. And a lot of docs found solace in that, I'm afraid. That's as much as I can tell you. It won't be the last of the synthetic opioids that comes out, of course. Yes?
Can you talk a little bit about like prescribing morphine for geriatric treatment?
Well, the question is about prescribing buprenorphine for the geriatric patient, and I think the issue again is what are you targeting? If the geriatric patient has a substance use disorder, and it's specifically opioid use disorder, then the prescribing obligations shouldn't be any different than for the general public, except that, keep in mind one of the things that Dr. Masaki has made very clear to me over time, which is whatever it is you're planning on prescribing for the older patient, divide it into and then divide it into again. That's not untrue for buprenorphine as well. As it happens, the potency of buprenorphine is very high, and I have patients who at one point were on 80 to 100 milligrams of methadone and are doing fine on 2 to 3 milligrams a day of buprenorphine. Now the actual max on buprenorphine is 32 milligrams per day. So that suggests to you that the route of action of buprenorphine may also be somewhat different from the other opioids. But regardless, you can find yourself managing withdrawal symptoms and cravings very nicely at very low doses. So there's no real reason to start off somebody who's elderly with anything much more than 0.5 milligrams per day. Anyway, back to the point about what to give it for. If you're giving it for pain, actually, buprenorphine comes both as a compound with naloxone and as an individual medication. And the one that is authorized for management of pain is straight buprenorphine. The buprenorphine plus naloxone combination is intended just for substance use disorder. I think it's a good drug in the sense that it's a very safe drug. Most of the chronic or long-term patients that we've seen in Queens who have needed transition from more potent opioids have tolerated buprenorphine very well and found that that's given them, while not complete relief from their chronic pain, then adequate relief to allow them to enjoy life. I don't have no investment in the company. Looking forward to something even better coming down the line, but you've been very patient. Thank you. I think you should go eat.